Hi, good evening. My name is Colita Joaquin, and I'm a family nurse practitioner student at United States University. Today, I'll be presenting a cardiovascular case involving a patient I saw at Senior Medical Associates on January 28, 2026. All patient identifiers have been changed to protect my patient's privacy. Identifying data, patient's initials are MH, 67-year-old Asian male, born on November 15, 1958. He presented to the clinic unaccompanied and was a reliable historian. For chief complaint, he stated, "My shortness of breath and mild chest pressure start when I walk." History of present illness. The patient is 67-year-old Asian male who presents with a 3-month history of progressively worsening exertional dyspnea accompanied by mild chest pressure. Symptoms occur after walking approximately 1 to 2 blocks on level ground and reliably resolve within several minutes of rest. He describes the chest pressure as dull, non-radiating, and rated 3 out of 10 at its worst. Symptoms occur only with exertion and are not present at rest. He denies dizziness, syncope, palpitations, nausea, diaphoresis, jaw or arm pain, orthopnea, paroxysmal nocturnal dyspnea, or lower extremity edema. He has not attempted any treatments for these symptoms and reports that they have begun to limit his daily walking routine, prompting today's visit. His past medical history is significant only for hyperlipidemia. He denies a history of coronary artery disease, heart failure, hypertension, diabetes mellitus, asthma, or chronic obstructive pulmonary disease. Medications. He takes atorvastatin 20 milligrams orally at bedtime and denies use of over-the-counter cardiac or respiratory medications. For allergies, he has no known drug allergies. For pertinent family and social history, family history is notable for a father who experienced a myocardial infarction in his early 70s. There is no known family history of cardiomyopathy or sudden cardiac disease or death. Socially, the patient is retired and lives independently. He denies tobacco use and illicit drug use and reports rare alcohol consumption. He previously walked daily for exercise but has reduced activity due to symptoms. For the review of systems, constitutional, he denies fever, chills, or unintended weight loss. Cardiovascular, he reports exertional dyspnea and chest pressure and denies palpitations, syncope, orthopnea, or edema. For respiratory, he reports exertional shortness of breath and denies cough or wheezing. All other symptoms were reviewed and are negative. For objective finding, vital signs today show a blood pressure of 132 over 78 millimeters of mercury, heart rate of 72 beats per minute, respiratory rate of 16 breaths per minute, oxygen saturation of 97% on room air. The height is 69 inches, weight is 163 pounds, and BMI of 24. On physical examination, the patient appears well and in no acute distress. Cardiovascular examination reveals irregular rate and rhythm with normal S1 and S2 and no murmurs, no rubs or gallops. There is no jugular venous distension. Peripheral pulses are intact and symmetric with no lower extremity edema. For pulmonary examination, reveals clear lung fields bilaterally without wheezes, rales, or crackles. The remainder of the physical examination is unremarkable. For assessment and differential diagnosis, this is a 67-year-old male presenting with exertional dyspnea and chest pressure concerning of a cardiac etiology. I discussed the case with my preceptor and we reviewed the following differential diagnosis. First, stable ischemic heart disease, which is the leading diagnosis. This is supported by predictable exertional chest pressure and dyspnea that reliably resolve with rest in an older adult with hyperlipidemia. In older adults, dyspnea may represent an anginal equivalent. Second, heart failure with preserved ejection fraction was considered due to exertional dyspnea in an older patient. However, the absence of orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, pulmonary crackles are signs of Volume overload makes this less likely. Third is pulmonary causes of dyspnea, such as chronic lung disease or deconditioning, are less likely given the associated chest pressure, normal lung examination, and lack of respiratory symptoms such as cough or wheezing. For primary working diagnosis, based on the patient's presentation, the primary working diagnosis is stable ischemic heart disease presenting as anginal equivalent. This is supported by predictable exertional dyspnea and mild chest pressure that resolve with rest in an older male with cardiovascular risk factors including age, male sex, hyperlipidemia, and family history of myocardial infarction. The absence of symptoms at rest, stable vital signs, and benign cardiopulmonary examinations support a stable rather than acute ischemic process. For the plan, given concern for underlying coronary artery disease, the plan is as follows. For diagnostics, we agreed to obtain a 12-lead electrocardiogram in clinic along with laboratory studies including a lipid panel, basic metabolic panel, and hemoglobin A1C to further assess cardiovascular risk factors. Per ACC or AHA guidelines for stable chest pain, we also agreed to proceed with non-invasive cardiac stress testing to evaluate for myocardial ischemia. For treatment, the patient will continue atorvastatin therapy. No anti-anginal medications will be initiated at this time, pending diagnostic results. For the patient education, the patient was educated on warning symptoms, including chest pain at rest, worsening shortness of breath, dizziness, or syncope. He was advised to avoid strenuous exertion until cardiac evaluation is complete. We also discussed cardiovascular risk reduction through diet, physical activity as tolerated, and medication adherence. For follow-up, the patient will follow up in clinic in 2 weeks to review diagnostic results and determine the need for cardiology referral. Closing synthesis statement. In summary, this is a 67-year-old male presenting with exertional dyspnea and chest pressure, most consistent with stable ischemic heart disease. Diagnostic testing has been initiated to further evaluate for coronary artery disease and guide management. Thank you, classmates and professor.